My name is Kerry Hall. I'm the Clinical Nurse Consultant, Interventional Cardiology at the Sunshine Coast Hospital and Health Service. I'll be discussing today the implementation and the establishment of a new position, Nurse Practitioner, for Acute Coronary Syndrome, ACS, in the Sunshine Coast Hospital and Health Service. The aim is a formal nurse-led program in the identification and management of acute coronary syndrome patients in a designated area through appropriate use of invasive investigations and follow-up in nurse-led specialist clinics, thus promoting effective use of resources, increasing the uptake of cardiac rehabilitation and reducing 6-month readmission rates. Introducing you to the role of the nurse practitioner and how the role impacts the Australian health system, what areas of health would benefit from the implementation of the nurse practitioner, and what research has been done into the position. A nurse practitioner's scope of practice extends beyond that of a registered nurse to provide preventative healthcare measures and support strategies within a specific demographic or specialist field. With further education and through extensive experience, they have the ability to perform advanced and extended clinical roles both autonomously and collaboratively. Positive health reform has been evidenced with the implementation of the nurse practitioner role with more than 50 years' existence in other countries. In Australia, the role was first introduced in the 1990s with the first appointments in 2001. However, to date, there are barriers exist surrounding the implementation and utilisation of the role due to a lack of understanding. With increasing pressures on the health system in Australia due to an ageing population, chronic disease and preventable illnesses, the nurse practitioner role is ideally suited to alleviate the burden on the health system and medical practitioners, thus providing optimal health care. Cardiovascular disease is one of Australia's largest health problems, and despite improvements, it still remains one of the biggest burdens on our economy to date. According to the National Heart Foundation, best practice care for people with coronary heart disease can reduce the incidence of subsequent cardiovascular events and improve quality of life and survival. Quality, accessibility, and the need for increased access to care are major concerns of hospitals and the healthcare industry today. Patient-centred approach that sees people actively increasing their awareness, making informed choices, and thereby realising a more integrated and robust existence. Cook and Lyons state, experienced cardiology nurse practitioners enhance the quality of cardiac care and are well placed to provide expert survivorship care, managing side effects related to myocardial infarction, acute coronary syndrome, and the subsequent treatments. Research comparing the effectiveness of nurse-led models of follow-up care shows similar outcomes in quality of life or rate of disease reoccurrence to physician-led care. However, offers significantly higher rates of patient satisfaction due to a holistic approach. Stryker contends that nurse practitioners are ideally placed to provide the integrated and long-term follow-up care that acute coronary syndrome patients need as they are focused on symptom management, a big concern for survivors of cardiovascular disease. Rehabilitation goals of the Sunshine Coast Hospital and Health Service cardiac services are to educate and support patients on managing their condition, ensure appropriate medical follow-up and pharmacological management, improve quality of life, and prevent readmission to hospital. It is through rehabilitation that the nurse practitioner role is the most effective and has the greatest benefits to patient care and to the service. Overview of the nurse practitioner model and service improvement plan for the Sunshine Coast Hospital and Health Service. The acute coronary syndrome nurse practitioner role is based on the identified needs, analysing the current service and the impact of the future demands that will have on the health service. Current and future consumer needs identified guide the principles and objectives with which will form the basis of the nurse practitioner service. The following diagram provides an overview of the nurse practitioner model / service improvement plan for the implementation of the ACS nurse practitioner. As you can see, there are 7 key components which will be discussed in further slides. Health Service Description. The Sunshine Coast Hospital and Health Service Integrated Cardiovascular Service provides a hub and spoke model delivery and specialist care for all adults with cardiac disease in the Sunshine Coast region. The hub is located at the Sunshine Coast University Hospital, SCU, with supporting spokes located at the Nambour General Hospital, Gympie Health Service, Mullaney Soldiers Memorial Hospital and Caloundra Health Service. The multidisciplinary team care is provided at the hub and to all the spokes to varying degrees through inpatient and outpatient services. The service objectives: to review patients post uncomplicated percutaneous coronary intervention or PCI and acute coronary syndrome, to manage outpatient service capacity by improve patient access to cardiology outpatient appointments, reduce cardiology outpatient wait lists, provide sufficient review time of patients post-PCI, provide a holistic patient care to reduce avoidable hospital readmissions, and provide a financially sustainable model. The objectives and functions of the nurse practitioner role are as follows: to improve patient access to outpatient appointments, to reduce outpatient waitlist times, provide sufficient review time of patients post-PCI, to provide a holistic patient care to reduce avoidable hospital readmissions, and finally to provide a financially stable model. The primary function of the ACS NP role is through case management and consultancy as follows. Referrals will be triaged by the interventional cardiologist. Patients requiring primary and secondary prevention, reviewing post-PCI, hypertension management, chest pain management and investigations will be referred to the ACS nurse practitioner. Assessments including pathology tests and thorough interpretations will also be required. To establish and consider diagnoses and differential diagnosis options, autonomous case management of ACS patients, teaching and mentoring provided to patients, families and carers, and to provide coaching and education to cardiology and allied health staff to develop their capacity and capabilities regarding early intervention and management of this population group. Finally, to develop and implement protocols and guidelines based on evidence-based practice. The process of care will commence with the patient assessment in the outpatient clinics. The patient will be assessed and health risks identified. From that assessment, I will develop and implement a treatment plan individualised for each patient based on theoretical knowledge, the clinical expertise and patient care acceptability. The follow-up and referral process will be as per the following pathway diagram, which shows the processes for both inpatient and outpatients referred to the clinics. The process for referring patients to the ACS/post-PCI clinics include 2 cohorts of patients, post-PCI and those with chest pain management or ACS. The post-PCI clinics will be referred from the cardiac cath lab, coronary care or 3D, otherwise known as the cardiac step-down ward. Patients to meet criteria must have a normal ejection fraction, be over the age of 18 years and post-uncomplicated PCI. Chest pain management or ACS patients will be referred from emergency department, 3D or the coronary care ward. Patients to meet criteria must have chest pain with negative troponins, blood pressure management and arrhythmias which have been reverted with medications. Both groups of patients will be referred to the clinics either via the heart lab or an online cath lab program or a completed referral form. Patients booked into the ACS NP clinics will be seen within a 2 to 3 week time frame. Clinics will operate every Tuesday and Friday mornings. The exclusion criteria for patients with post-PCI will include cardiomyopathy, valvular heart disease, patients awaiting CABG or otherwise known as coronary artery bypass grafts, These patients will be referred to the treating cardiologist to review in outpatient clinics. The exclusion criteria for those patients referred to the chest pain management or ACS clinics will include syncope, patients with arrhythmias that are not reverted with medications, or new patients referred from the GP. These patients will be referred to the treating cardiologist to review in the outpatient clinics. Diagnostic and investigation protocol will be as follows. The pathology will include full blood count, coags, UNEs and LFTs, fasting lipids, swabs, MCS, and troponin and CK. The medical imaging will include chest x-rays. All invasive investigations should be authorised by the medical consultant first. Pharmacological therapy. This group of high-risk medications will not be included in the ACS NP scope of prescribing and are drugs with a narrow therapeutic range, drugs requiring specialised monitoring or interpretation, cytotoxic medications, non-steroidal anti-inflammatory drugs or COX-2 inhibitors, opiate analgesics, aminoglycosides, anti-epileptics, and insulin. Drug references used for the prescribing and dosing will fall under the Therapeutics Guidelines, the Australian Medicines Handbook, within the parameters of Queensland Health Policies and Procedures, keeping the scope of best practice in mind. These include cardiac drugs of aspirin, clopidogrel, ticagrelor and prasugrel, and beta blockers including atenolol and metoprolol. The enablers and barriers is necessary to advance the long-term sustainability and implementation of the ACS NP role within the cardiology department. Enablers include leadership is a fundamental requirement that will define the NP role and must commence at a personal level. Role extension is defined as the inclusion of a particular skill or area of practice responsibility that was not previously associated with the nurse's role. Role extension improves patient outcomes and service delivery. However, the long-term sustainability of these roles depends on appropriate organisational support. Networking. Networking can be defined as the exchange of information or services among individuals, groups or institutions. Networking provides opportunities for nurse practitioners to build strategic alliances across boundaries and to act as change agents at a clinical, operational and strategic level. Providing value for cost framework, whilst improving the quality of cardiac outpatient services, is of utmost importance. The scope of the NP role provides the opportunity to undertake many necessary duties currently being performed by specialists. Though the intention of the NP role is to complement and not substitute the cardiologist position, the salary of both must be considered. The barriers include lack of awareness. So lack of awareness and knowledge surrounding the NP role and scope of practice as a whole has created considerable barriers, especially with implementation in practice and clinical settings. The leadership. Leadership discussed as enabler also has the potential to become a barrier for the position. Nurse practitioners, whilst recognise that leadership forms part of their role, not all nurses who undertake to become a nurse practitioner possess leadership skills and capabilities to carry out the role. Funding and changes to government. State and Commonwealth funding, as well as internal or organisational funding and budget arrangements, have a considerable effect on the full-time equivalent on offer to the NP role. Changes to government, executive, organisational structures and advocates of the NP role can also have a tremendous impact on the sustainability and future of the position. The education. Postgraduate education is required for a nurse practitioner to be educationally prepared. However, it does not provide the clinical hands-on experience and knowledge essential to undertake the role. Implementation strategy. The objectives for the implementation strategy are as follows. To clarify the scope of the ACS NP role through consultation with key stakeholders to develop clear and concise position descriptions and professional boundaries. Consult with the cardiology multidisciplinary team to reduce the lack of understanding of the role. provide education and promote awareness of the role to wider healthcare settings, including other specialty areas, establish regular meetings with key stakeholders to facilitate open communication and ongoing support, implement cardiology ACS nurse-led clinics, to implement a ACS care plan, implementation of chest pain action plan, and to provide mentorship to existing nurse practitioners and cardiac care coordinators. Role implementation is a continuous process involving many steps, with the ultimate goal of moving in a forward direction whilst continually analysing and developing the position. Full implementation of the role takes time. For a novice NP role, full implementation can take up to 3 to 5 years. The evaluation strategy. Initial evaluation of the NP role and model of care should focus on outcomes related to safety and efficiency, acceptance and satisfaction, costs and role transfer. The evaluation practice review to ensure the following: safe incorporation of new technologies and procedures, quality and safe healthcare, maintenance of standards, to provide each patient with an individual plan of care consistent with his or her special needs and alterations in cardiac function, deliver care according to the individual plan in a cost-effective manner for both the patient, hospital and health service, act as a patient's and family's advocate to ensure individualised needs are acknowledged, to incorporate all disciplines and ensure the patient's individualised health needs are fulfilled with appropriate referrals for ongoing care, to create a working environment that promotes and encourages professional growth and personal satisfaction for all multidisciplinary staff, and finally provide and promote continuing education for all levels of staff facilitated by a contractual staff development program that utilises internal and external education and training, in-service education, self-directed learning packages and research and quality projects, and finally to improve the quality of healthcare. Evaluation outcomes. Identification of outcomes for the service helps lay the foundation for monitoring performance, success and effectiveness. Outcomes that will be evaluated in the cardiology outpatient department are: prevention of admissions to hospital through monitoring of the number of admissions with chest pain, ACS, and in particular the readmission rates of patients seen by the NP service. Improved follow-up by specialists for patients admitted with chest pain or related diagnoses. Improve optimisation and compliance of dual antiplatelet medications and adherence to medications, which are the recommended pharmacological treatment in post-MI and chest pain management. And finally, effective patient education and compliance with agreed self-management strategies. Methods will be evaluated using qualitative and quantitative data requiring no ethical approval. This will be gathered by means of the following: referral numbers and sources, telephone triage data, nurse-led clinic attendances, clinic waiting times, preventable hospital admissions, and optimisation of medications and compliance. Regular service audits will ensure the NP service performance is monitored and evaluated to promote continual development and success. Evaluation is a collaborative process involving the NP, doctors, the multidisciplinary team, and the patients themselves. In conclusion of this presentation, coronary heart disease is among the most preventable diseases. The ACS NP role offers an innovative model of care that has potential to benefit patients affected by coronary heart disease. The ACS NP has the potential to optimise the cardiac experience, improve patient satisfaction, reduce future supportive care needs, improve patient flows, as well as generate cost efficiencies within cardiac care organisations. The process and framework required for the successful implementation of the ACS NP role is as complex and dynamic as the role itself. Effective planning and implementation strategies and careful consideration of stakeholder involvement should create environmental conditions necessary to support the role development and long-term integration in an already diverse healthcare system.